because it's not like we're not going over any like actual test material, you know what I mean? So if you're at work, if you're at church, you can, if you have to walk away or whatever, I'm going to send it out. I'm also going to try to make this not super long. Because I want you guys to have time to study and do all the things you need to do. So, I'm using my Surface with my pen. So I'm going to try to share my screen. And I'm going to try to write on my screen, and you let me know if it works. I don't know if it's going to work. I hope it works. I don't know. I still have a couple of people coming in. How are we feeling about content and studying?
I think I'm feeling good besides like the PVCs and stuff like that. That's where in the heart blocks is where I get really confused, I think still.
Me
Okay.
too.
I will say PVCs is on like the worksheet. We did not go over PVCs and PACs in class. So that is not going to be testable material. The PVCs and the PACs are not testable because we did not even touch it in class. I'm going to go over it because we're going to go over our worksheet today. But heart blocks are obviously fair game.
For the packet, can I just skip those since I have no idea what I'm even looking at, like the PVCs and PACs? Can I just go on to the next? Okay, thank you.
That's totally fine. That's totally fine. And I'm going to go through it right now because we're going to go through this whole packet together. Okay. All right. So we aren't doing the junctional either. Correct. That is correct. Junctional is not going to be tested. It is not going to be tested. Okay. All right. I am going to switch over. I don't know if I'm going to be able to see the chat while I'm like writing on my other screen. So if people are trying to get in, I hope that they communicate with their friends. Where'd you go? This is my first time doing this with my.
I have a quick question.
Oh, here we go. Okay.
Jessica, if I
Yeah, what's
could. The VSIMs, it is
Yes.
due today, correct?
Yes, I think I emailed Joanna back. I didn't fix the date on Brightspace. So if there was a miscommunication about that, that's on me. Just have it done by tomorrow. Okay.
Wait a minute.
Yeah.
What you say now? What VSIM?
Your assignment, is it
it's due
Shapiro?
today?
Carl Shapiro.
Yeah.
Oh,
If you
okay.
haven't done it, just do it tomorrow. Okay. I would rather you study and be ready for your exam than worry about a VSIM. Okay.
I emailed mine to you since there was like nowhere to turn it in. I just sent it to you on the email.
I saw that, and I also since I changed the due date, it should be in Brightspace. It should be in week 1. I see.
Okay, thank you. I'll go like return it in there.
Oh no, it's still not. Okay, hold on. Let me add this. No, that's not what I want. Go back. Assignments. Aha.
For the VSIM, can we stick with like I kept the man alive? But
yes,
like
you can.
Okay.
Yeah, you don't even have to explain. Yes, ma'am. Okay, so there is now a thingy, and then there's a Vincent Brody in the next week. How did I do that? How did I mess that up?
And then somebody asked in the chat for the EKG worksheet, are we even doing the junctional ones?
No, no, that is not, junctional is not testable material.
Okay, sounds good, thanks.
Okay. All right, let me, where is my thing? Where's my thing? Sorry, this is my first time trying to share it from here. I want it open over here. Now will it let me draw on here? Okay, it will. Erase. No, erase. Thank you. Okay. Can you see my screen?
Yes.
All right. By the way, for tomorrow, did you know that if you hold down your control button and then go up or down with your mouse, you can zoom in on your screen? Did you know that?
No.
Okay. So there is a question on your exam that you're going to look at this rhythm strip and you're going to be like, I can't see I can't see this. I can't see all the thingies. Where's the boxes? I need you to zoom. Okay, tell your friends because not everybody's on here. So tell your friends about that little trick. Okay.
Is it possible for you to send like a paper one to the proctor just in case?
Ooh, I don't know. But you can still do that in an ATI. I know for a fact that you can zoom in with ATI.
Okay.
Hold
Okay.
control and then scroll up or down. I don't remember which one. With your mouse, and it will zoom in on your computer. If you're on a computer right now, you can try it right now and see how it works. Okay, so we did the first page, right?
Yes.
Together. Okay, so the first page we had normal sinus rhythm. For the first one, for the second one, we had sinus tachycardia. For the third one, we had sinus bradycardia. Did we do page 2?
We did, yes.
Okay. So page 2, we had sinus tachycardia, and then the second one was sinus rhythm, and the third one was sinus bradycardia. So then we left off on this page, correct?
Yes.
Okay. All right. So we have. I want to make this bigger. Can I make you bigger? Without? No. Go over there.
Ginger needs you to let her in the ring.
Thank you. Thank you, ma'am. Okay. So with our first strip, we have, what is our rate? 1, 2, 3, 4, 5, 6, 7, 8, 9.
90.
90.
Can you see my writing?
Yes.
Yes, now we can.
Oh, good. Thank God. Okay. I'm like, please let this work because I forgot that stupid little camera. Okay, is my rhythm regular or irregular?
Irregular.
I agree. Do I have a P wave?
No.
No.
No. So that means I have no PR interval, correct?
Correct. Not measurable.
Okay. So what is my interpretation of this rhythm?
AFib.
Controlled AFib.
Control AFib.
Control AFib.
Good. Now, if I needed treatment for this, what would my treatment be?
Metoprolol.
Beta blockers.
And probably a blood thinner.
Eliquis.
Amiodarone.
Yes, 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 yes. Anti-coag, calcium channel blockers, antiarrhythmics. Spelling arrhythmics wrong. Whoop. Very good. Very, very good. Okay. So, with our next one, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. What is my rate?
170.
170. Is it regular?
Regular.
Yes.
Do I have a P wave?
No.
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 Is my PR interval measurable?
Not measurable.
No.
What is this?
SVT.
SVT.
Uncontrolled VTAC.
Nope. This is SVT. So when I say, do I have a P wave? What is happening with my P wave when we're in SVT?
It's there. It's just going too
It's
fast.
hidden.
You can't see
It's
it.
hidden. Okay. Because this guy right here, that's your T wave. Okay. I'm gonna switch over to red. I know you guys like red. Okay. So are we good on that one? Somebody said VTAC. I want you to, especially when we get to VTAC, I want you to really look at VTAC and see what it looks like. Because this with T waves, VTAC has no T waves. It has no P waves, it has no T waves. It is just a very large ventricular rhythm, and we'll get there. So let's go to the next one. We have 1, 2, 3, 4, 5, 6, 7, 8, 9.
90.
90.
Is it regular or irregular?
Irregular.
Regular.
Do I have a P wave?
No.
No.
No. Do I have a PR interval?
Not measurable.
No. Okay. So what is this?
Controlled
Controlled
AFib.
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 What are my two rules for
No P wave
AFib?
and a regular heartbeat.
Whoop. I can't write today. Oh my God. Irregular rhythm. Okay. All right. I have 1, 2, 3, 4, 5, 6, 7, 8. Almost 9, but 8. So that gives me a rhythm of
80.
80. Why is it not converting it to a nice font? Is it regular or irregular?
Irregular.
Irregular.
Hmm. Do I have a P wave?
No.
No.
No. PR interval?
Non-measurable.
Nope. So what is this?
Atrial.
What
Controlled.
is it?
Oh, sorry.
Controlled
A flutter.
The
A
flutter.
flutter. Woo. Okay. And this is 2 to 1, 3 to 1. Because I have 1, 2, 1, 2. I got 1, 2, 3. I got 1, 2. So I got a 3 to 1 in there. So I'm gonna put both. You're not gonna need that for your exam tomorrow. I'm just kind of putting it out there because it is characteristic of A flutter.
Miss Simmons, can you let Toy again, please?
Yes. Okay.
Can we go over the treatment for A flutter again? Because I can't remember it like off the top of my head.
Yeah, so your treatment for A flutter and AFib are the same because they are both atrial. So
That's probably not coming to me.
So we're talking beta blockers, antiarrhythmics, anticoagulants. So AFib and A flutter are going to be the same treatment. And in some cases, you can even do synchronized cardioversion with AFib and A flutter. It is not great. It doesn't work a lot. A lot of people still need a beta blocker antiarrhythmic, but some people it does work, which is really nice. Okay, so for this one, especially because we have a like half of a beat right here, I wouldn't be surprised if you gave me either 1, 2, 3, 4, 5, 6, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. I would accept 200. I wrote 200 on my paper. And if you wrote 190, that would be fine too. Okay. So I put a rate of 200. Am I regular or irregular?
Regular.
Regular.
Okay. Do I have a P wave?
No.
Not visibly. Do I have a PR interval?
Unmeasurable.
Okay. So what is this?
SVT.
And what is my first treatment?
Cardioversion.
The vaso
Maneuver.
or to cough, or like you said, splash cold water.
Vagal maneuver. So bear down, cough, ice water on your face. But your most common vasovagal maneuver is going to be bearing down. What is my second?
Adenosine.
Cardioversion.
Adenosine.
6 mgs and 12 mgs.
6 milligrams first.
And then 12.
Then 12.
And given fast.
Very fast. As fast as you can, because why?
Very short half-life.
It has a very short half-life. Very good. Very good. Okay. All right. My next one. What is my rate?
70.
70. Is it regular or irregular?
Irregular.
Irregular.
Do I have a P wave?
No.
No. What is this?
A controlled
A flutter.
Yes, A flutter. It looks a little different, but that's okay because everybody's different and everybody's going to look a little bit different. And I have 3 to 1, I got 2 to 1, and it looks like it's almost every other. Okay. Ugh. This one makes me uncomfortable. What is this?
VFib.
VFib equals
Defib.
Defib.
VFib defib. Okay. So my rate is 0. Rhythm ain't none. P wave? No, she don't live here. PR? Mm-mm. Interpretation? This is ventricular fibrillation, which equals dead. Okay? Dead as a doornail. Dead can't get deader. Okay? How many joules are we defibrillating at?
Is it 200?
200. Because why? Because they're already dead. Okay? Synchronized cardioversion, what am I starting at when we're talking about joules?
50.
150?
50 up to?
Oh, 50.
200.
50 to 200, but we're not starting at 200, we're starting at 50 because guess what? They're still alive. Okay? All right, so the next one, the person that said VTach, this next one is ventricular tachycardia. Okay? You see it has a very, very wide QRS complex. This is a wide QRS complex. Okay. What is my first question with VTach?
Is it
Do they have a
pulse or not?
pulse?
My question or my answer is yes. What do I do?
Are they symptomatic?
I don't care if they're symptomatic or not. This is not
It's
sustainable.
not CPR.
No,
or-
I have a pulse.
I'm sorry, I didn't hear.
Cardioversion?
Like, do they have a pulse or no?
I have a pulse. Yes, my patient has a pulse.
Cardioversion.
Cardioversion. Thank you.
I said this to somebody at clinical, so I don't know if it'll help somebody else, but it helped them. But to me, they always look like tombstones for VTach.
I like that.
So if you look
Yeah.
at it and looks like kind of like tombstones, it's VTach.
So I do like that. Yes. Also, I will say it can also be a little bit more narrow. So VTach can look a little bit different sometimes. Can you still see my screen?
Yeah.
Yes.
Like on my Google Images? I switched screens.
No,
No.
we just see the worksheet.
Okay. Let me switch. Now, do you see it?
Yes.
Okay. So this is called monomorphic versus polymorphic. monomorphic is this very, like these like humps, okay? So, let me see. It's very similar. The shape is not changing. It's very almost like a circular at the top. And then this is called polymorphic. These are both VTAC. They just look a little bit different. So this polymorphic is that it has a lot of different shapes. Oop, what happened? No, I don't want to go to Instagram. Oh, well, I guess that does, it's bigger. Never mind. It's fine. So see how we have a little bit of changing shapes, but it's still VTAC. We have a very wide QRS complex. Over here, it's more narrow, and then it gets more like wider here, and then it goes back to a narrow. This is called polymorphic, so it has multiple shapes. Monomorphic, it's one shape. So do you see they are both VTAC? They're both wide QRS complex. There is no P wave, there is nothing atrial about this rhythm. Okay, do we see that? So here too, this is still VTAC. This is a very wide QRS complex, right? But it looks a little bit different because every human is different. Every heart is different. There is always going to be a variable, okay? This one, this is your monomorphic. Do you see my little cursor that's moving? Can you see it?
But there's no difference in like the treatment of the two?
There is no difference of treatment. The only time there is a difference in treatment is when it is pulseless or they have a pulse. This is a good one. This is a good picture. So this is saying that monomorphic, it looks different because it originates from the same ventricular focus. And this polymorphic, where did it say it? Here we go. Here we go. Here it is. VTAC originating from the right ventricle, VTAC originating from the left ventricle, which is why it looks different. Do I need you to know that? No. In real life, I just need you to know that VTAC may look like the right side or it may look like the left side. That's what I need you to take away from this, okay? Because just because they look different doesn't mean they're not both VTAC. Do we feel okay about that?
Yeah.
Okay.
Yes, thank you.
Does anyone disagree that they do not feel good about that? Okay. All right. Next one. What is this? Dead. Dead. D-E-A-D. Dead. A systole. Is this a shockable rhythm?
No.
No.
No. Number one is what?
CPR.
CPR.
CPR. Number two is what? Yes,
Epinephrine.
ACLS, which includes
Epi.
ACLS. Yes, ACLS is inclusive for all life-saving medications, and the protocol. Okay, so I'm not going to write epi. I'm going to write our ACLS protocol because if you're giving epi, you should 100% be following ACLS if you're giving epi. Okay.
We would never get a question that like that was the answer and you would have both epi and ACLS, would we?
Absolutely not.
Okay.
Absolutely not. Never in a million years. Okay. All right. What is my rate here?
140.
140. Is it regular?
Yes.
Yes. Do I have a P wave?
No.
No.
No, she don't live here. What is this?
VTech.
VTech.
VTAC. Very
Hey.
good.
Can you get me a spoon and get me a lemon one?
I would also like a lemon one.
Oh,
What
sorry.
are we having lemon?
I'm
Is
sending
ice?
my 10-year-old on tasks because every
You're
time you say dead, he looks horrified. And then
Oh
he starts
God, I'm
giggling.
sorry. I'm so sorry. Okay, so what is my first question?
Do they have a pulse?
Do they have a pulse?
Okay, so now this time my answer is no. What do I do?
Defib.
What do I do?
CPR?
CPR. Then what do I do?
Defib.
Defibrillate. Because guess what? I don't have a defibrillator next to every patient just waiting for them to have pulseless VTAC. Okay? So while somebody goes and gets the AED or the defibrillator or the crash cart, someone else is doing CPR. Okay? You never, never, never delay CPR. Never. Okay? All right, next one. What is this?
VFib.
VFib.
VFib. Does anybody, and I need you to tell me, does anybody having a difficult time understanding what is VFib, what does it look like, and what do I do? There are no stupid questions here. I want more than anything is your success, and I can't have you be successful if you don't understand the content. So, are
I
we
just have a
okay?
problem with looking at the EKG and knowing if there's a P wave or not, unless I have something else to compare it to. That's where my problem comes in.
Okay, so we're having more problems with P waves.
Well,
Somebody else
just in
was talking.
comparison to see it. Oh, I'm sorry.
No,
Do we
you're
use
okay. Who?
for
Somebody else said
VTAC?
something. I can't see your faces. I can't see the chat, so I need you to talk to
It
me.
was me, Sharia. For this particular one, I had a hard time interpreting if it was VFib. That was just
You mean,
right. Yeah.
okay, so did you
With
think
this,
maybe because you were looking over here that it looked like VTAC?
I thought yeah.
Okay.
I
I
couldn't tell.
I see that. I can see that. Okay. So one thing that I want you to see with this rhythm is that there is nothing uniform about this. What does VTAC have? What does this say? VTAC is regular. If you look at this VTAC, this is regular. Do you see that? Is there anything regular about this rhythm?
No.
So it cannot be VTAC. Irregular. They like to refer to this as a chaotic rhythm. Do you see how that feels like chaos?
Yes.
Looks chaotic. There is no uniformity about it. That's how you can distinguish whether it's VFib or VTAC, especially when it looks like this. Does that help, Sharia?
Yes, it absolutely does. Thank you.
Good, perfect. Okay, we talked about this one a little tiny bit when I told you asystole is flat. It can have a very small wave like this, okay? But when it looks like this, what did I say that was?
Fine.
VFib.
Fine. VFib. So this is still what?
Shockable.
Shockable. Yes. Good job. Everybody good on that? Because we're going to move on and I am going to go over these PVCs and PACs a little bit. Do we have any, because we're about to go over these PVCs, PACs, and then we're going into heart blocks. So once we move on, we are at this point, we're kind of going to be a little bit done with atrial and ventricular rhythms. So like in an emergency, emergent VTAC or chronic VTAC?
Do we use amiodarone for VTAC?
Acute? Hold on. I want to say no, and I want to be sure when I say it.
I thought you could use it if it's full.
Hold on. Just let me be sure before I answer.
I guess either.
Just hold on a second. Acute VTAC with or without a pulse.
Well, okay, so if they have a pulse, would we use it?
Okay, so IV amiodarone is a widely used and effective antiarrhythmic medication for managing acute ventricular tachycardia, particularly in life-threatening or unstable situations. Yes, amiodarone can be given in life-threatening or unstable VTAC. So that means pulseless or with a pulse. It says amiodarone is a primary antiarrhythmic considered after initial attempts at CPR and defibrillation with epinephrine when those have failed to restore a rhythm. So it is not especially when we're talking about like crisis, cardiac arrest, pulseless VTAC, amiodarone is not going to be your first thing, right? Your first, number one for a pulseless VTAC is CPR. Number two is going to be ACLS defibrillation. Number three is then going to come with your drugs, okay? Amiodarone is never going to come before epinephrine when we're talking about pulseless. Does that make sense?
Yeah.
I'm pretty sure it was on the slide. I'm pretty sure it was one of the treatments on the slide. Why isn't my thing working?
Can I make sure I have this right? So,
yeah.
Okay. Yes, I had it written down in my notes, and I don't know where it came from, so I was just.
Atropine,
I guess I just
yes.
wanted to
Atropine raises your heart rate. Atropine is the treatment for
bradycardia.
Symptomatic bradycardia.
Okay, and then amiodarone lowers it, correct?
Amiodarone is an antiarrhythmic, so it works by So amiodarone is a highly effective antiarrhythmic medication that works by slowing down the electrical signals in the heart to help it beat more regularly. So yes, does it result in a slower heart rate? Yes. But what actually happens is that it's slowing the electrical activity. Because what's happening in AFib, what's happening in VTAC is that the electrical activity is going crazy. And you have to find control. Does that make sense?
Yes. Sorry, I was just trying to get those correct.
Don't say sorry. Listen, your question is going to be something that one of these other 23 people are thinking. Okay? This is your safe place to say something you think is stupid. This is your safe place to say something that whatever question you have. Okay? So I don't want you to apologize. I want you to ask me because I would rather tell you than you make a mistake because you didn't ask. Okay?
Thank you.
You're welcome. Okay, so what is a PAC? A PAC is an early P wave. Okay. It is characterized by a premature P wave. Usually.
Oh, we lost your screen, I think.
Oh no. I have you back. Oh, I accidentally hit the stop sharing button. Can I move this thing? Hide. Ooh, I can hide it. There you go. You can see my screen again?
Yeah, we can see it.
Okay. Usually followed by a narrow QRS. And it is also followed by a compensatory pause. Okay. So everything about this rhythm is regular except for this beat. Do you see that? Yes, no, maybe?
Yeah.
Yes.
Okay. So this guy right here is your early P wave. This guy is called a compensatory pause. Okay. You see how this space is longer than every other space between each beat? That is called a compensatory pause. This right here, see how this is longer than all the others? This is called a compensatory pause. Okay. This is something that you see within heart blocks and PACs. Okay. Now, usually this is not very symptomatic. This is something that just kind of happens. I want to redraw that in a nicer way. And usually does not need any treatment. Okay. No. This is your compensatory pause. And this is your PAC. Okay. So PACs are usually not symptomatic. It just kind of happens. It's just an early firing of your SA node. So what we call this is normal sinus rhythm with unifocal PAC because it only happened once. Okay. The next one is PVC. Premature ventricular contraction. Okay. So this is a PVC. This is a PVC. By the way, we do not count PVC beats as our heartbeat. And do you notice that this strip looks different than all your other strips? Anybody? Anybody notice?
Yeah, it's
Yeah.
like the beat doesn't even look sort of similar to the other ones up.
It's upside down. Okay.
Jess, Kiera's asking to be let back in. She got booted out.
Okay. Thank you. It's upside down. Why is it upside down? Because it's a very simple answer. It's a different lead. Okay. Usually we read these strips in lead 2, and that is our most beautiful, easy lead for anyone to read. You've seen an EKG, right?
Yes.
Why isn't it letting me write? Hello? Okay. You know how on an EKG, like that one sheet of paper that prints out when you have an EKG, it has like 6 different things on it, and only one of them even resembles a heart rate? That's because it's showing you every single different lead. So the most normal lead to look at when you're looking at an ECG or EKG is lead 2. Okay. So how many beats is this? What is the heart rate for this? If I told you that these PVCs are not counted.
40.
40. Okay. Is this regular?
No.
It don't look regular to me. Can you have a regular heart rate with PVCs?
Yes.
Yes. Yes, you can. Do I have a P wave?
Yes.
Yes, I do. It's right here and right here. And this one is really tiny and it looks upside down. Okay. What is my PR interval?
0.16.
Jess, Kiera's still on hold.
Why? I let her in. There we go. So when I was doing mine, I got, it looks like I got 4 boxes there. This one I have 1, 2, 3, 4, maybe 5. On my paper, I wrote 0.2, 1, 2, 3, 4. But now that I'm looking at it, it really kind of looks like a 4.5. 1, 2, 3, 4. All right, I'm going to call it 4. So I'm going to have my PR interval be 0.16. Okay. There's a couple more things about PVCs. So do not count PVCs as beats. Okay. These are extra early beats from the ventricle. So just like a PVC or PAC is a premature P wave, these are premature ventricular. So it's an extra early beat from the ventricles. Okay. And then
So like these are only like dangerous if you're getting like multiple.
I'm going to talk about that in 1 second. So it looks like wide, bizarre. They literally use the word bizarre. Q QRS followed by an inverted T wave. Okay, so this is a PVC. This is a PVC. Okay. So you have a very wide, weird looking QRS followed by an inverted T wave. Okay. So you still have your P waves. Everything about this is normal except for these premature ventricular beats. Okay. So what is my rate here?
50.
50. Is it regular?
No.
I disagree. I believe it is regular without the PVCs. This is also a PVC. Because we're not counting the PVCs as regular beats, right? So all of my other R to R, this beat and this beat, are regular. Do I have a P wave?
Yes.
Yes. My PR interval. I have 1,
0.16.
2, 3, 4. 1, 2, 3, 4. I agree. 0.16. So what is this rhythm?
Sinus Brady with PVCs.
Brady.
Sinus bradycardia with PVCs. When do PVCs become dangerous?
In runs.
Of?
Is it 5
How
or
many?
more?
Three PVCs that run consecutively. So they have to be in a row. PVC, PVC, PVC is a run of VTAC. 3 PVCs in a row equals VTAC. Anytime you ever see your patient go into VTAC, what do you need to do? And then they come out. Your patient has a run of 3 PVCs, a run of VTAC. What do you need to do?
Go check on them.
Check their pulse.
Yes. Yeah. What else do you do? Okay. You guys, that was very good. That was a very good answer. But what I'm looking for is notify the provider. But yes, 100% the first thing you should do is check on your patient because patient safety comes first, right? But when you know that your patient is safe and they're okay, you must notify the provider. Okay? All right. Next page. So, what is my rate?
50.
Is this regular or irregular?
Regular.
Irregular.
It's regular except for the pause.
1, 2, 3, 4, 5, 6, 7.5. 1, 2, 3, 4, 5, 6, 7.5. I agree. This is a regular rhythm because other than this guy, everything else is regular. Do I have a P wave?
Yes.
Yes. What is my PR interval?
0.12.
Ooh, PR interval.
0.8.
2, 3, 4. How many boxes are you counting from the here to here?
0.16.
0.16. From here to here. 1, 2, 3, 4. Here to here. 1, 2, 3, 4. Do y'all see how I got that? Yes? No? No?
Zoom
Okay.
back in. You said,
Am I zoomed?
so
Can
I'm
you see
coming
it?
at the wrong spot.
So you see my two lines, this line and this line.
I thought so. Okay.
Okay, so I have 1 box, 2 box, 3 box, 4 box. 4 times 0.04 equals 0.16. Everybody see that?
Yes.
Okay.
My apologies. I was looking at number 2.
Oh, you're
Sorry.
fine. You're fine. What is my QRS here?
0.08.
I agree. 1, 2. 2 boxes. 1, 2. 1, 2. 0.08. Okay. So what is this rhythm?
Sinus Brady with a PAC.
Mm-hmm. Yes. All right. PACs, PVCs are not going to be testable. It is a very, very important thing to know about and to keep in your filing cabinet about PVCs. PVCs are very common. When you start on the floor, when you start in your nursing career, you are going to see PVCs more than any other arrhythmia. I promise you that. Because it is very normal for people to have, even you and I sitting right here. You ever feel like when you're sitting there, you ever feel like your heart skips a beat? Anybody? No?
My grandma was in the hospital last night and she was having AFib with PVCs on the monitor.
So she was probably feeling a lot of things, a fluttering sensation, maybe a skipped beat sensation.
Yeah, her heart rate was at 142. So
yeah. If you've ever just been sitting there and all of a sudden you just kind of feel this weird feeling in your chest, like you just feel like I don't know how to describe it, but it almost feels like something just dropped in your chest. That is probably a PVC. And it happens all the time. It happens for no reason sometimes. It's never really a problem unless it starts happening significantly or it's happening in consecutive beats. That's when it becomes a problem. Okay. All right. So let's get into heart blocks. So this first heart block, what is my rate?
50.
50. Is it regular or irregular?
Regular?
I would
Except
say
the
it's irregular. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Wow. 1, 2, 3, 4. Oh. Ooh. Okay. I see where you're coming from. I'll agree. Regular. Do I have a P wave?
Yes.
Yes. Did I just stop sharing?
Question. You just said it's regular.
I still see it.
What did you say, Annalisa?
You said it's regular?
So I changed my answer because at first I wrote irregular, but if you actually count the big boxes, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. This is a half. This is a half. Other than your heart block, like what's happening here. Well, I don't know. Let me think about it. Because
like
your
regular
R to
with
R
periods
interval,
of
your R to R interval here is regular, other than this portion. Monkey block be a regular. Yes, a Winky Bach, Wobitz type 1, which I just gave you the answer, but that's okay, is a regularly irregular rhythm, which means this is regular, and this is irregular. So we refer to that as regularly irregular. Does that make sense? Regularly irregular. So really, if we think about this, all of those PACs, all of those PVCs that we said were regular, they are regularly irregular because there's only one portion of it where the arrhythmia occurs that's irregular. Okay. So I have P waves, yes. So now I have from here to here, I have 1, 2, 3, 4, 5 small boxes. From here to here, I have 1, 2, 3, 4, 5, 6, 7 boxes. From here to here, I have 1, 2, 3, 4, 5, 6, 7, 8, 9 boxes. And then here's my P wave. No QRS. So I have a dropped beat. So what is my saying? I have longer, drop. Now I have a Winky Bach. Second degree type 1. Okay. How do we feel about that? Anybody, anywhere?
That's like the one I feel good about.
I agree. I feel like most people have the least amount of issues with a Winky Bach because it's really, really easy to remember that longer drop. Now I have a Winky Bach. Like that saying is so easy to remember. Okay. What is my QRS complex?
Prolonged.
QRS.
Oh. I can't see the boxes on my paper. 0.08.
It looks like one. I see one box. Does anybody see more than one box? Maybe
I think
half
on
of a
some
box?
of them it's like
Maybe a
I
half
think
of
on
a
some of them
box.
it's like 1.5.
Yeah. Because on my paper, I wrote 0.06. Because I called it 1.5 too. And then for my PR interval, I said gets progressively longer. Okay. All right. Next. What is my rate?
Oh, can we go over the treatment again for that one?
Oh, yeah, sorry. So, excuse me. Treatment for our Mobitz, or I'm sorry, our second degree type 1, which can also be a Mobitz 1, Winky Bach. What is my treatment?
Beta blockers?
Oxygen?
So, is my patient symptomatic or asymptomatic? If my patient is asymptomatic, we're going to call cardio.
And then would it
If
be
my patient
atropine?
is symptomatic, especially bradycardic, we're going to give atropine.
Or pacemaker, right?
No, not for a type 1, not for a Winky Bach.
Okay, I have that written in the wrong place then.
We're going to give atropine. We're going to give beta blockers. We're going to give digoxin. What is digoxin?
Antiarrhythmic.
It increases contractility.
Is digoxin an antiarrhythmic? Is that its classification of drug? No. It is a cardiac glycoside.
The positive inotrope.
That is its drug classification. And it is used to treat heart conditions such as heart failure and irregular heartbeats. So it increases the force of the heart muscles contractions. So it helps pump blood more efficiently. And then it also slows the electrical signals in the heart. So it works in two ways. It's not only an antiarrhythmic, it also works by strengthening the contractions. So it's increasing your cardiac output. Okay. That's why it's a really good drug for patients with heart failure. Okay. Next. What is my rate?
60.
60. Ooh. Okay. Am I regular or irregular?
Irregular.
1, 2, 3, 4. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. I would say it's kind of regular. It's pretty regular. Your R to R intervals are not that far off. So remember, your regularity relies on R to R interval. That is its only characteristic. Okay. Do I have a P wave?
Yes.
Yes.
Okay. All right. So let's start from the front. Here is the beginning of my P wave. Okay. I have 1, 1, 2. Oh, that's kind of hard to see. 1, 2, 3. Ugh. 1, 2, 3, 4, 5, 6, 7, 8, 9. One, 2, 3, 4, 5, 6, 7, 8, 9. One, 2, 3, 4, 5, 6, 7, 8, 9. Feels pretty consistent. 1, 2, 3, 4, 5, 6, 7, 8, 9. So, what is 9 times 0.04?
0.36.
What is a normal PR interval?
0.06 to 0.12.
No. PR.
0.12 to 0.20.
Yes. So what is this?
Prolonged.
Prolonged. And is it prolonged with every beat?
Yes.
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 So what is this?
First
A
degree.
type 1.
This is a first degree block. It can't be a type 1. This one is a type 1.
I meant degree, but in my head, I don't know why. I always want to
That's
call
okay,
it
but you need to distinguish what's what with the correct name, right? So make sure, because I don't want you to get confused between a first degree and a type 1. Okay? Because it's not always going to say Winky Bach. You have to be able to recognize it by this name. It's not always going to have the word Winky Bach. Okay? So, what is my key characteristic for a first degree block?
the prolonged PR
Regularity.
interval.
Is it prolonged PR?
The PR interval is prolonged and constant. Keyword is constant. Okay? So they are the same. Every single PR interval is the same, and it is always followed by a QRS. Okay? So what is my treatment?
Nothing.
Usually no treatment. It's usually asymptomatic and benign. Okay. If you have to, if they do require treatment, it's going to be beta blockers, and calcium channel blockers. If they require treatment, but usually it's no treatment. Okay. Next page. What is my rate?
50.
50.
50. Am I regular or irregular?
Irregular.
Irregular.
I agree. You know, maybe if we had longer than a 6-second standard strip, it could be a regularly irregular pattern, because you are seeing this R to R and this R to R that have a regular pattern, but the rate is so slow that it's hard to say if it is truly regular. Does that make sense? I wouldn't ask a question like that with a beat like that. So, but I did mark on my paper, woo, that it was irregular. Do I have a P wave?
Yes.
Yes.
Yeah. Okay. What is my PR interval?
Can you?
1, 2, 3, 4. 1, 2, 3, 4. One, two. One, two, three, 4. What is my PR interval?
0.16.
I agree. Ooh. What is my QRS?
.06.
Yeah, I'll go with that. 0.06. What is my rhythm?
Second degree type 2.
Why?
Because the PR is the same.
And
you drop a
And then
QRS.
you're missing the QRS.
missing a QRS. So this is a second degree. Ooh. Block. Mobitz. Type 2. Okay. What is my treatment?
Pacing? Is it pacing?
Transcutaneous
I think this
pacing?
one depends on if they're symptomatic or not.
So remember, every time we get to the next stage of heart block, it gets a little more serious. Okay. So with our first degree, we don't really have any treatment. With our second degree type 1, we have atropine, beta blockers, digoxin. Rarely do we see pacing. Okay. So with our second degree Mobitz 2, we're going to be going a little bit further. Okay. So with this, we absolutely need temporary pacing. Okay. This often requires a permanent pacer. Okay. This arrhythmia has a greater risk to lead to what?
A third degree.
A third degree complete heart block. So you have a higher risk of this second degree Mobitz turning into a third degree greater than the other heart blocks. Okay. Which is why it's probably a good idea to just get your permanent pacer now. Okay. All right. Our next one. What is our rate?
40.
40.
40.
Okay. Are we regular?
No.
No. Irregular.
The regular R to R on like the first part seems regular, and then you have a big space, and then like it's just that last.
It is irregular. So this first one was 10 boxes in between, the second one was 9, and the third one was like 12. So this is in an irregular rhythm. Do I have a P wave?
Yes.
Yes. Okay. Okay, so my first PR interval, 1, 2, 3, 4, 5. My second PR interval, 1, 2, 3, 4, 5, 6, 7, 8. My third PR interval, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And then boom, drop. Okay. So what do I have here?
Second degree type 2.
Type what?
Type 1.
Type 1.
Type 1. Longer, longer, longer drop. Now I have a winky Bach, which is a type 1 second degree. Okay. We're almost there. What is this rate?
70.
70. Am I regular?
Yes.
Yes. Oh. Do I have a P wave?
Yes.
Yes. Okay. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Okay. My PR interval is 0.24. What is my QRS? Here's my Q. Here's the end of my S. 1, 2. Here's my Q. Here's my S. 1, 2. Here's my Q. Here's my S. 1, 2. What is my QRS complex?
I'm gonna fight you.
0.08.
0.08. Don't forget that 0.8. Okay. What is my interpretation?
First degree.
First degree.
Amen. First degree block. Okay. All right. What's my rate here?
120.
What?
Sorry.
1, 2,
70.
3, 4, 5.
I went to the next
6,
page.
7. Oh, I was like, wait, what? 70. Regular or irregular?
Irregular.
Do I have a P wave?
Yes.
Yes.
Hmm?
Understand.
One, 2, 3, 4. 1, 2, 3, 4. Whoop. One, 2, 3, 4. 1, 2, 3, 4. Whoop. Okay. What is my PR interval?
Zero point, what do I have? 0.16.
What is my QRS?
0.08.
No, it might be a little longer. 1, 2. Yeah. I might call that a 2.5. 1, 2, 3. Remember, we're going to the end of the S. 1, 2, 3. I'm going to call that a 2.5. So it's going to be 0.10. Okay. What is my interpretation?
Second degree type 2.
Mm-hmm. Second degree. Well, that's 2. So ER constant. So, okay. Let me. So this could be random. It could be a pattern. Pattern / random. Dropped QRS. Okay, because remember, your Winky Bach is always going to be a pattern. Always. Your Mobitz 2 can be random or it can be in a pattern. It doesn't have to be on that 4th beat like the Winky Bach does. It could be on the 5th beat. It could be on the 2nd beat. Okay. All right. What is my rate for this next one?
50.
50.
Am I regular or irregular?
Irregular.
Do I have a P wave?
Yes. No.
I got a lot of P waves. I got a P wave here. I got a P wave here. I got a P wave here. I got a P wave here and here and here and here and here. That's a lot of P waves. There's no uniformity whatsoever. What does that mean?
3rd degree.
3rd degree, baby. Okay. Now I want to be clear because last term, my students did this thing where they thought they had to count the P waves versus the QRS. We're not doing that, okay? Because they got other things wrong because they were counting P waves, counting QRS, and then they were like misinterpreting Winky Box and all other things because they weren't counting their boxes, okay? So when you think about a Winky Bach, you know that the PR interval gets progressively longer. It's not short and then long and then short and then really, really long and then, oh, no, there's nothing. And then, oh, right? With a 2nd degree type 2, Mobitz 2, the PR is constant. It does not change. So if you have, look how long this is. Look how short this is. This one's dropped. This one is dropped. This one, it's long. This one, it don't have nothing. This one is super short. There is no correlation between P waves and Q waves or QRS complexes in this strip. Can you see that?
I don't think I know.
Okay. So, is my PR interval constant? What is the answer?
No.
No. Is my PR interval progressively longer and drop a QRS on 4th beat?
Yes. I said yes.
The answer is no.
No.
Is my P interval progressively getting longer and then dropping a QRS on the 4th beat?
No.
No. If you ever have trouble figuring out if this is a 3rd degree block, I need you to ask those 2 questions. Is my PR interval constant? No. Is my PR interval progressively getting longer and then dropping a QRS on the 4th beat? No. It is a 3rd degree complete heart block. Does that make sense? Does that help at all?
Yes, it does.
Okay.
Yeah, kind of.
If the answers to those two questions are no, and we're specifically talking about heart blocks, the answer is a third degree. Okay. Let's look at some more so this guy, this has a lot of P waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, I didn't care to be counting P waves, but in this specific strip, you can really identify that there are so many P waves and there are no correlation with the QRS. And we know, is my PR constant? I have no idea. Look how many P waves I have. This is crazy. Is my PR interval consistently getting longer and then dropping on the third or on the fourth beat? No, I have a QRS, I have a P wave, P wave, P wave, QRS, P wave, P wave, P wave, P wave, QR. Oh, not even a P wave here, a QRS. There's no correlation between your P's and Q's. Okay. This one is a good one. This one has. Whoop. Go away. Hey. Okay. Okay. Yeah. I'm almost done. Okay. I love you. Hey, turn the TV on there. Okay. All right, sorry. Okay, so this is another third degree block, and I have a P wave here. It is miles away from my QRS, and then I have another P wave, another P wave, another P wave. Stop it. Okay. Is this a P wave or a T wave? I have no idea. P, P. There's no P wave before my QRS. If it is, that's pretty long, but it's not as long as this first one. That's crazy. So I have a very long PR here. I have a really, really short PR here. I have a moderately long PR here. But what is it about a Winky Bach? It is progressively longer. It doesn't go back and forth between long and short. It goes long, longer, 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 drop. Okay. So here we have a normal sinus rhythm. We have a first degree block with a prolonged PR interval. We have a second degree, which has a dropped QRS here and here. And then here we have a third degree with multiple P waves with no corresponding QRS. How are we doing? Does that make sense?
Yes.
Yes.
Okay. Do we need to go over junctional rhythms?
Not
No.
if they are not gonna be on the test. I don't need to add
No.
anything else.
Okay, good. I really don't think it's necessary either. So, hour and 49 minutes. Do you feel any better than you did 2 hours ago?
Yes.
Okay. Good. I'm glad. Chelsea said clarification from clinical. Winky Bach, my kid is up. You better go back to sleep. So Chelsea said clarification from clinical. Winky Bach will always be the fourth drop, correct? Yes. Always. This is why Maria Ross upsets me. This is why she upsets me. This is why I provided her with the answer key, because a Winky Bach is a pattern. It is a pattern. It is a longer, longer, longer drop. Now I have a Winky Bach. If it didn't go by that every single time, we couldn't use the saying. Right? We stopped listening to her. Good. I'm glad you did. This is exact. She didn't even have the answer key, did she?
She did, but she actually, so I felt that I had an understanding after watching the video, but Maria like kind of threw me off some, and now I'm just trying to figure it out. I understand it some a little better than I did, but she confused me so much.
Okay. I am going to talk to her, and I will not allow her to do this again. This is the second time in a row, and I really, really thought that I was going to nip it by providing the answer key, and that makes me very upset that that still happened, and I'm sorry for that.
So I'm just going to stay up and watch videos.
Do you feel better now, Latasha?
Honestly, no. I feel better about the 3rd degree heart block for sure.
I'm not
feel
going to
better
ask
about
you what she said to you because I don't want to confuse anyone else. We can talk about that tomorrow.
I just got to make myself comfortable. It's a big test tomorrow, and this is on there, and I'm just kind of jumbled, to be honest with you.
Okay.
But I'm going to work on it the best that I can and hope for the best outcome.
So when you're thinking about your interpretation, what I want you to do is I want you to make a list of each rhythm's key characteristics. That's what I want you to do. Okay.
Okay.
So a normal sinus rhythm, and get out a piece of paper, write this down.
I am.
Okay. Your normal sinus rhythm, you have a rate that's between 60 and 100. You have a regular rhythm, a normal PR, and a normal QRS. Everything is normal. Honky dory. Okay?
Yes.
Sinus tachycardia. You have a rate from 100 to 150. You have a present P wave. Your PR interval is normal. Your QRS is normal. Your rhythm, your R to R interval is normal. Everything is normal except for the rate. Okay?
Okay.
So now we go to AFib, A flutter.
So those two, I can, by the looks of those, I can readily identify those two.
Good.
Because of the sawtooth and the...
Wait a second. We forgot sinus bradycardia.
Yes.
Sinus bradycardia, everything is normal except the rate is slow. It's less than 60 beats. Now remember, sinus bradycardia can be asymptomatic or it can be symptomatic. If the patient is asymptomatic, there is no treatment.
And they're symptomatic, that's atropine, correct?
If they are symptomatic, then you have atropine.
Okay.
Okay. Then we go to AFib, aflutter. There are only 2 questions, and both questions have to have a yes. Or no. Both questions have to have a no. Is there a P wave? No. Is the rhythm regular? Is the R to R interval the same? No. Both of those questions have to be answered no to be AFib, aflutter. Okay? If it is less than 100 beats, it is controlled. If it is more than 100 beats, it is uncontrolled. Okay?
Yes.
So now let's go to SVT. SVT is a rate between 151 and 200. There is no discernible P wave. I can't see her. She's hiding. Okay? The rhythm is regular. Your first line treatment is a vagal maneuver. Your second line treatment is adenosine. 6 milligrams, then 12 milligrams. Given as a very fast push because it has a short half-life. VTAC is a rate between 100 and 250. It is characterized by wide QRS complexes, no P wave, and it is a regular rhythm. Okay. The first question is, do I have a pulse? Pulseless VTAC is treated by number 1, CPR, number 2, defibrillation. If I have a pulse, then we need to give amiodarone and cardioversion. Synchronized, don't forget that, synchronized cardioversion. Okay?
Okay.
VFib, ventricular fibrillation, is a chaotic rhythm. There is nothing regular about it. There is no P wave. There is no QRS. It is completely chaos. It can be bigger, it can be smaller. There is nothing regular about it. Ventricular fibrillation equals DEAD. VFib, DFib. Okay.
Okay.
First, CPR. Second, defibrillation. Okay.
Okay.
Never delay CPR or anything unless the only thing in the whole world that you delay CPR is if you are in an unsafe situation and you cannot safely get to that patient because you cannot put yourself at risk. You can't, if you die, nobody's giving CPR, right? The only thing that can delay CPR is an unsafe situation. Okay. Now we go to asystole. Asystole is a flat line, or it can have a very small wave like an ocean, just a small ripple in the water. No fibrillation. Okay. There is no Nothing, no electrical activity. Asystole is immediate CPR. It is a non-shockable rhythm. Okay?
Okay.
A first degree block is it has one characteristic. That's it, just one. It has a prolonged PR interval. That's it. Second degree type 1 Winky Bach. The PR interval gets progressively longer, and every fourth beat is a dropped QRS. Every time. Progressively longer PR interval with every fourth beat is a dropped QRS. The patient will probably need beta blockers, calcium channel blockers, antiarrhythmics, whichever the doctor wants to prescribe. Very rarely will you have pacing. Okay?
Okay.
A second degree type 2 Mobitz 2 is going to be a constant PR interval. It is not changing. It can be normal, it can be prolonged, but it is constant. And then you have either a pattern of dropped QRS or it can be random dropped QRS.
Okay.
But the PR interval is constant. The treatment is going to be temporary pacing, most likely transcutaneous, which means it's through the skin. And they have to get a temporary or a permanent pacer because untreated Mobitz 2 leads to a third degree block. So they need a permanent pacer.
Okay.
A third degree block. There are two questions. Is my PR interval constant? No. Does my PR interval progressively get longer with a dropped QRS on the fourth beat? No. There is no correlation between P waves and QRS. No correlation at all. You must have a temporary pacer. I'm sorry, did I say temporary? I meant permanent. You must have a permanent pacer. It's going to start temporary because they're in the ER and they have to be temporarily paced before we get to the cath lab and put in a pacemaker. Okay. You can treat if the patient is severely symptomatic with a complete heart block. You can give them atropine to try to increase, to try to do something, try to increase something. Okay. It's not going to fix anything, but it can help cardiac output in the temporary acute phase before you get into the cath lab. Okay.
Okay.
I feel like that's
Thank
everything.
you.
You're welcome. Did I miss anything?
No.
Okay. So think about your characteristics. Tiffany said there's a YouTube video, Level Up RN. Tiffany, can you send that YouTube link in the group email for everyone, please?
Yes.
Thank you, ma'am. Before we get off, because it's 2:30 and my kid's already awake, unfortunately. He usually sleeps till 3. Do you have any questions?
I just have one. The second degree type 1, you said the treatment was the medications, but on the slide it says that causes the second degree type 1. The beta blockers and the calcium channel blockers, and the treatment was.
It can. So when you're thinking about causation, a lot of arrhythmias can be caused by drugs. Too much of them, if they're over medicated by them, if their levels are off, specifically digoxin. Yeah, Ginger, it has to be submitted. If the drug levels are too high, any of these drugs can cause you to have an arrhythmia. Electrolyte disturbances can cause you to have an arrhythmia. Okay, that's why it's really important that we treat the underlying cause. If there is an underlying cause like hypokalemia, like digoxin toxicity, you have to treat the underlying cause, but also you also have to treat the arrhythmia to try to get them out of it, because you don't want someone sustaining an arrhythmia. That's not good. Okay? Does that make sense? Okay. Any other questions?
So when you say stop the underlying cause, let's say they're taking like a beta blocker, you'll stop or slow down the beta blockers, and if that doesn't work, you'll go to like a second phase of it, and like.
So yes, so if you were having an arrhythmia because of too much metoprolol or whatever drug, you would most likely they would stop that drug completely if that was the cause. And I think I did record this, so I'm going to send this out as soon as it's ready to be downloaded. Okay.
Thank you.
Thank you.
Thank you.
You're welcome. All right, guys. I will see you in the morning. Do not forget to do your math test. The practice math worksheet has to be done before your test tomorrow, or you won't get credit before your first math exam.
Also, for the math, does it show like what you got? It just shows complete. It doesn't say like what you got right or wrong on it.
I'll try to change that. If it says complete, that means you got a 10 out of 10. If you missed any, if it says 9, if it says incomplete, that means you missed 1 or more.
Okay, thank you.
Okay, so I'll try to change the properties of it so that you can see what you got wrong.
Thank you.
Okay.
That was my next question.
I'll try to
Because I
do
want
that
to know
right
what
now.
I got wrong. Thank you.
You're welcome. Okay, everybody good? And remember, the first day of class, we went over math. That it was only like a half hour long. You guys have that recording. So if you need to go over math a little bit, please watch the end of that video. Okay? Okay. I'm getting off here. See you tomorrow. Goodbye.